We'll be signing on. So hello, everyone, and welcome to our K-12 seminar for August. Thank you so much for signing on at this special time so that we could accommodate our speaker today. I'm Dr. Lauren Baker. I'm a K-12 scholar at UW-Madison, and I'm the organizer for this event. Someone maybe needs to mute. We'll have a so this session is recorded, just so everybody knows. It will be posted on CAIRIBU after the session with the slides. And at the end of the talk, we're going to have a question and answer session. So please do feel free to enter your questions into the chat box so that we can kickstart the discussion. I also want to encourage you to please mute if you are not a speaker, so that there aren't any interruptions during the talk. Because it's important for us to keep track of attendance at these events, if you are a guest with us, someone who wouldn't normally be attending, please chat your email to Catherine Davis. And finally, we will have a post-event survey today, and a link to that survey will be placed in the chat mid-session. So please fill that out for us because your feedback is really valuable to us. So without further ado, I am happy to introduce our speaker for today, K-12 scholar, Dr. Eva Raphael. Dr. Raphael obtained her bachelor's in molecular and cell biology and her master's in public health from the University of California, Berkeley. And she completed her medical school at Emory University in Atlanta, Georgia. She is currently a family medicine physician at the Family Health Center at San Francisco General Hospital and assistant professor of epidemiology and biostatistics in family and community medicine at the University of California, San Francisco. Her general research interest is in common infections, and particularly urinary tract infection. During her MPH, she studied transmission dynamics of gram-negative bacteria, and she's applying that expertise with her clinical experience to address community-onset antimicrobial-resistant urinary tract infections in women. Dr. Raphael is currently studying trends in antimicrobial-resistant UTI across different healthcare systems, and also how social and neighborhood level risk factors contribute to antimicrobial-resistant UTI. So we can't wait to hear about that. So please take it away, Eva.
Great, thank you. And it's exciting to present in this space remotely. So let's see. So I don't have any disclosures. And today I'll be talking about a continuum of work in the field that Dr. Baker just presented. So I want to start with some basics on drug resistance. So the CDC came out with this report in 2019, where this is a follow-up to their 2013 report, where they actually realized that they underreported or calculated drug-resistant infections in the US. And what they found is that each year, drug-resistant bacteria and fungi cause 2+ million infections and more than 35,000 deaths. One of the major findings of their report was that although drug resistance is more common in healthcare and hospital settings, there is a rise in drug resistance in community settings as well. And obviously, CDC efforts have been wonderful at actually trying to control hospital-acquired infections, but there's still yet a lot of work to be done for community-onset infections. So I know I'm talking to a group of urologists and people who study urinary tract syndromes and conditions. So I'll just quickly glean over UTI. So it's the most common infection seen in primary care. I see patients in family medicine and lots of urinary complaints. It's also the largest proportion of reason for urology specialty care, especially for recurrent UTI. And about 150 million people per year develop UTIs in the world. And from 2006 to 2010, this represented in the US about 40 million ambulatory care visits. And that's, and in 2011, this represented $3 billion also in the US. So quick definition, what is a UTI? It's a bladder infection. Symptoms are urgency, dysuria, hematuria. And the most common causes of UTI are gram-negative bacteria, including E. coli, Klebsiella, and these others. And I'm going to be talking mostly about extended spectrum beta-lactamase resistance. So this confers resistance to ceftazidime or cefotaxime, so cephalosporins, and inhibition by clavulanic acid. So this will be the specific drug resistance type I will be focusing during my talk. So quickly, some recognized risk factors for UTIs. If you've ever had one, you know. So women are more likely to have a UTI, prior UTI or vaginal infections, sexual activity, trauma or instrumentation like catheters, but so are diabetes and obesity. And then there are some genetic susceptibilities and anatomic abnormalities that predispose people to having a simple, not necessarily drug-resistant UTI. For risk factors for drug-resistant UTIs, so prior antibiotic use has been very well described, as well as recurrent UTIs, but there are some new risk factors, or new-ish. Over the last 10 years, I think there's been more and more data pointing to travel and companion animals and food, in particular poultry. And there's a very nice review paper that actually goes over a lot of these risk factors for drug-resistant UTIs. And we see that we find ESBL-producing XBEC strains in a variety of environmental reservoirs. So these various sequence types have been found in water sources, dogs and cats, but also cattle, chicken, houseflies, and vegetables. So a lot of data showing that food may be a potential reservoir for these drug-resistant organisms, which can potentially cause a UTI. So I also want to decipher or kind of talk specifically about selection versus transmission of drug resistance. So for drug-resistant or antimicrobial resistance or AMR strain selection, those factors that I kind of mentioned already were the antibiotics that are used clinically, but mainly the antibiotics used in livestock husbandry. So in a population of bacteria, there's this driver that will then push for the drug-resistant organisms to strive, right? We get rid of the ones that are susceptible to that antibiotic. When we talk about transmission or prevalence of already drug-resistant strains, here, this is where the contaminated food, so eating food or travel, which probably is related to food also, companion animals, and all of these kind of factors fall into that category. So there, the train has already left the station. We're not even talking about selection anymore. The organism is already resistant. And this is sort of a cute framework for how we think about both selection and transmission drivers, where they come into play in community infections and healthcare associated questions. So the central hypothesis of the work that I'm presenting will be that drug-resistant UTIs are caused by a limited number of E. coli genotypes with common point sources, so potentially acting as outbreaks. And as we're living in a pandemic, we are very familiar with thinking about outbreaks, right? So I'll be talking about a series of projects that have kind of led us to try to answer these questions. Some of this work has already been published, but other is still in progress. So to be able to just answer what is going on in the community in San Francisco where I work, we decided to look at 4 different healthcare facilities. So as I mentioned before, the prevalence of ESBL E. coli has been increasing worldwide, but there's some data that shows that it actually varies geographically. However, a lot of reports that actually focus on the ESBL E. coli are often based on just a single healthcare site. So here we're trying to answer this question of, well, how does ESBL E. coli look like in the city? So we looked at urine and non-urine E. coli infections over 6 years. And so this is based on just getting antibiograms from hospitals, which report drug-resistant profiles of different organisms every year. And so we obtained them from the San Francisco General Hospital, which is a county hospital, and they report in conjunction with the hospital information, affiliated clinic information, Laguna Honda is a public skilled nursing facility, also report their antibiograms separately. We also obtained antibiograms from the UCSF Medical Center and the San Francisco VA. And so we looked at the change in frequency of ESBL E. coli between 2012 and 2018. And here, what I want to point out is that really what this slide shows is that we have much greater prevalence of ESBL, ceftriaxone resistance, and trimethoprim sulfamethoxazole resistance at the skilled nursing facility, which is not a surprise, right? We know that skilled nursing facilities kind of act as reservoirs for drug-resistant infections, which then led to our other question, which was, well, how did that change over time? And so for here, I present both urine and non-urine. Our prior slide was all urine isolates only. But in light blue, you have the county hospital, so the general and its clinics, the skilled nursing facility in green, and in orange, UCSF, and in dark blue, the VA hospital. And change in ESBL frequency over time increased significantly for urine isolates in the county hospital and its clinics, and at the VA, and for non-urine in at the county hospital as well. So we saw those trends, but it's unclear what those increases were due to, which led us to our second question, our second paper based on this, which actually just came out today. So if you want to read the paper, you can click on, or I guess you can look up the little, it's not a hyperlink, but the link. So here, the question we wanted to answer was, okay, was this increase in urine ESBL E. coli taking place in hospital settings? So is this what we would kind of expect, right? That healthcare associated infections are kind of pushing or driving this? Or did it happen in community settings? Kind of what is the lay of the land here? And our hypothesis was that the increase in ESBL E. coli may depend on the clinical setting, but that there may be potentially other factors at play given the prior work that's been done on ESBL E. coli. So this is an observational study. We focus just on the San Francisco General Hospital and its affiliated clinics. We obtained data from the electronic health record system from 2014 to the beginning of 2020. So right at the cutoff of the pandemic, we realized that looking past the pandemic would have asked a very different question. And we essentially dichotomized our analyses by healthcare onset / associated. So these are bacteriuria, so including all urine cultures that are obtained greater than 48 hours after hospital admission, or an individual who was hospitalized in the last 90 days, or in someone living at the skilled nursing facility, which we obtained data from directly from the general. And then we defined community-onset bacteria as a urine culture that was sent less than 48 hours after hospital admission, so following the CDC guideline about how to differentiate both, or an individual who was seen in an outpatient clinical setting, so ED or outpatient clinic, who was not hospitalized. And we did marginal trends estimates from logistic regressions to evaluate annual change of prevalence in ESBL E. coli bacteria amongst all bacteriuria. We also did comparisons between drug for ESBL amongst drug-resistant E. coli to see if there was something special about ESBL E. coli potentially. And then we looked at demographic risk factors for ESBL E. coli bacteria. So overall, we had information on more than 13,000 urine cultures that grew an identifying identifiable organism. As you know, those of you who are clinicians, we send urine cultures that don't grow anything, or mixed gram positives. About 9,000 of those grew E. coli, representing more than 6,000 patients. So lots of recurrent urine cultures being sent. And the majority of those samples actually came from community-onset bacteriuria. In terms of demographics, so what I want to point out is that the majority of our patients were between 35 to 64. They were women. Because of our population, the majority of the patients were Latinx, and the majority spoke English. And so here are the temporal trends for E. coli bacteria. So on the right, we have community onset bacteria, and on the right, the healthcare onset. And what we see is that those trends, so in the bars, you have, sorry, I'm trying to move the little table so that I can see what I'm actually talking about. But in the bar, you have the number of ESBL E. coli bacteria episodes, and the lines represent percent ESBL E. coli. And the point here is that community onset ESBL E. coli increased by about 1% per year. That change was greater in healthcare onset associated bacteria, where the increase or annual percent point change was 2.38% per year. And then when we looked at associations between demographic characteristics and having an ESBL E. coli bacteria, we found that for age over 65, so that age over 65, male gender and Latinx, race ethnicity were significant for community onset bacteria. That's in orange, and in green we have the healthcare onset associated bacteria, and for that only male gender was significant. There's no line for age over 65 just because the confidence intervals were extremely wide, and so it was not, I didn't think it would make sense to just show very wide confidence intervals that go to infinity. And this is probably because of a small sample size of patients who are over 65. So here we found some concerning trends in both community and healthcare onset of ESBL E. coli bacteria. And this led to other questions. So are there geographic clusters of ESBL E. coli if we see that there are certain populations that are perhaps more affected by it? And were those ESBL E. coli represented by few or many genotypes? So this is work that's currently in progress. And this is essentially the same data that we used for the study I just presented on, but what we did here is that we just mapped our samples, and we did some analyses to see if we actually could identify clusters and if we could identify hotspots of ESBL E. coli versus non-ESBL E. coli. So using those nice formulas that ArcMap does for you magically. So the take-home point here is that we did not find any clusters. We initially thought we did, but this was when we had included all episodes, and in working closely with spatial analysts, one cannot talk about spatial clusters or geographic clusters when there is more than one point associated with that specific address. So we mapped any ESBL E. coli bacteria at a specific address. We didn't show those actual addresses, versus in blue, any non-ESBL E. coli bacteria. And the distribution is all over the city, and there's no true pattern. But so, what do we do now with this data, right? We initially thought, well, perhaps we're going to see something similar to what's been done prior in the same hospital system, which is what one of my mentors worked on, who's an expert on MRSA. They had found specific clusters of community onset MRSA, particularly USA 300 in San Francisco. But one needs to be thinking, and I'm sure all the urologists in the group are like, but of course, this makes sense, because MRSA is a person-to-person transmission. And given the data that we've given about ESBL and drug-resistant E. coli, those are probably, if they are foodborne, then we would actually expect a pretty broad distribution of those ESBL E. coli in the city, given the way that food is being produced and distributed, right? So we're gonna do a few more projects looking at neighborhood characteristics that are associated with ESBL E. coli bacteria. So essentially describing the food sources and the food environment, and looking at socioeconomic status and seeing if we see any sort of correlation. the next project, or this has been an ongoing project, that's actually the basis of my K-12 that we have been working on for the last 3 years or so, where we actually collected E. coli cultures. So as I kind of mentioned before, the San Francisco General Hospital, the microbiology laboratory processes urine cultures and actually all labs for both the hospital, Laguna Honda, which is the skilled nursing facility, which I talked about earlier, and the 15 clinics that are part of the San Francisco Health Network. So this is kind of the public health safety net clinic system. And so we collected about 1,000, we collected urine cultures from April to September 2019. We obtained patient medical records and we obtained data on those patients, and we got our geocoded addresses for those patients as well. We then, in collaboration with partners at UC Berkeley, we then worked to both identify the organisms, and we genotyped our organisms, so specifically E. coli. So we have about 551 E. coli isolates, and we did multi-locus sequence typing as well as multiplex PCR for the most common lineages. And we are now working on whole genome sequencing on the entire collection, as the multiplex PCR really identifies maybe 4 or 5 common genotypes. So here's what we found. So as you can see here, what's really interesting to see is that, unsurprisingly, ST131 was quite resistant to antibiotics and made up the majority of samples that were ESBL E. coli, as well as MDR. And here are the demographic characteristics by genotype. And so once again, we see the same pattern that we saw with our prior work, which is that patients are between 35 and 64. They're women, they're more likely to be Latinx, and they are more likely to speak English. And we are currently doing more analyses to see if we have any neighborhood associations with major E. coli sequence types. And we're currently also working on mediation analyses for neighborhood characteristics and antimicrobial resistance. So essentially using the genotype as the mediator. And we're doing more spatial analyses. So here's a preliminary table, or it's not table, a map, where we see that our STs pretty much follow the same distribution as our other urine isolates. So I realized that I finished this talk much quicker than I thought I would, even though I have 40 slides, but I did want to acknowledge the team at UCSF that has been mentoring and helping me with this work, and the team at UC Berkeley. And I want to acknowledge the funding that I had under my fellowship and this new K-12. So we have lots of time for questions.
Yes. So yeah, let's get that discussion started. Does anybody have any questions right off?
I had a quick question. The bacteria that are multi-drug resistant, are they more likely to, do the symptoms they cause the same as drug sensitive bacteria, and are they more likely to produce pyelonephritis, for example, or is the spectrum of the clinical spectrum of their disease about the same as drug sensitive organisms?
Yeah, that's a very good question. I think prior studies have shown that there are greater complications with drug-resistant organisms, and we've obtained further data. Actually, this work is based on a database of urine culture mainly, but we are getting further information about whether or not someone had complications. So these are our next questions, TBD.
There is a question in the chat. It says that studies have shown evolution of MDR in the gut in recurrent UTI patients. It would be interesting to see if there's association with travel to countries where over-the-counter antibiotics are available and how that seeds colonization over time.
Yeah, I totally agree. And so actually we are planning a project. So as I mentioned, This work is based in a public clinic, and given the demographics of the population in San Francisco, our patient population is very well represented by patients who identify as Latino or Latina. And now this is more anecdotal, and my data from my own primary care practice, which is that I have a very large immigrant population amongst my patients, and there is indeed a lot of back and forth from the US to their home countries. And even more anecdotally is the fact that I've had patients tell me, oh yeah, I got my husband to send me Cipro from El Salvador because I had a UTI, but it's not getting better. And so there has been prior work in Texas. I can't remember, I think maybe it was in El Paso, but they had a similar population, and they actually found that use of unprescribed or non-prescribed antibiotics did not differ between Latinx and non-Latinx patients. I don't know how much that actually pertains to my patient population or to the patient population in our study. There are reports coming from Latin America that show that Mexico has one of the highest prevalence of ESBL E. coli. I'm trying to remember the details of that paper, but it may be that travel and exposure in someone's home country may be one of the drivers that we are seeing in our population. So we will be doing some work where we will actually ask questions from respondents who have had drug-resistant or complicated UTIs to see if perhaps that may be a factor. There's another great paper that looked at colonization during travel over time. It was a study on, I think it was, I can't remember if they were traveling from Germany or from other Northern European countries, but this was travelers arriving to Southeast Asia. I want to say that maybe it was Thailand, and they looked at their gut microbiota or the E. coli in their gut, and they sequenced types that were present and how those changed on a daily basis, and indeed major changes. I don't think that paper actually looked at clinical outcomes of that colonization, but very interesting work.
Yeah, I had asked that question. Eva, great talk. Maria Hadjifrangisco studied uropathogenic E. coli. So it's very interesting. And the reason I asked it is exactly that, right? So depending on where you are in the world, the phylogenetic clades you carry in your gut as a commensal differ, right? With us having B2s and Ds and A1s. But if you go to Southeast Asia, that flips the coin. So it's very interesting to see, how travel back and forth would actually promote either switching of the clades transiently, and how would that influence longitudinal evolution?
Yeah, thank you for that point.
Can I come off mute for a question?
Go for it.
All right, so my name is Naz Siddiqui. I'm over at Duke, and I'm a clinician. So I have a question about, in terms of I'm curious about your age spread that you're finding. And, what we see in general is that though E. coli comprise, more than 80% of infections, when you get into an aging population, that really shifts. And so in people of 65 and older, we tend to see E. coli drops to only, kind of down by like 60% or fewer of those infections. So I'm just curious if you're looking at any other Klebsiella, Proteus, some of the other resistant strains, because I think that some of your age-related findings may be skewed by the fact that you're only looking at E. coli.
Yeah, so we do have data on all urine cultures. For those specific projects, we had decided to make it relatively simple and just focus on one organism. But we are planning on looking at Klebsiella and other organisms that may be drug resistant to actually characterize, especially I agree in that particular population, and maybe perhaps even in males, maybe, as you mentioned, other organisms may be at play. Yeah, thank you.
We do have another question from the chat. So Grace Morales says, I just want a clarification if your definition of bacteriuria included both asymptomatic and symptomatic? And did you look if drug resistance was linked more so with symptomatic bacteriuria?
Yeah, so in this work, we did combine both asymptomatic bacteria and urinary tract infection, and actually pyelonephritis, because this work was actually focused on urine culture data. Because we are pulling more data, we'll be able to see if people presented with, the generic ICD code for dysuria, or if they were actually diagnosed with pyelonephritis. We are, as I mentioned earlier, we are also interested to see if people were more likely to have complications or be admitted for, although urosepsis is not very common in the general population, it is the most common cause of sepsis. And so that is something we're also planning to look at.
Great. So I have probably a lower level question for those. So I'm not a clinician currently, and I had not really known that that UTIs could be really foodborne. And I kind of quickly looked it up while you were talking about it, like, oh, this is a thing. And so I'm just curious about how that works. Obviously, the test you were talking about, how that has to do with maybe stores and restaurants, that it all can play a role in these outbreaks of foodborne UTI. So can you just tell me a little bit like the mechanism?
Yeah, absolutely. And I had a slide on this, which I removed. I was like, people will know, but no, that's a great question. And actually this gets to Maria's point. So the idea is that one would eat food that perhaps is not cooked or not cooked enough. And that food contains, or, is contaminated with some organisms. So, there is plenty, in my prior work, I looked at drug-resistant non-pathogenic bacteria on spinach, and we found plenty, and we found that, these Pentoea, well, not Pentoea agglomerans, but more Pseudomonas aeruginosa, unfortunately, actually had drug-resistant genes that confirmed for ESBL, so CTXM, for those who are familiar, it's CTXM15. So anyways, not to say that non-pathogenic bacteria cannot be drug resistant, but so the idea would be that someone is eating a chicken salad, the chicken wasn't fully cooked, the organism, there's some drug resistant E. coli, or maybe it's not drug resistant, but it gets to the stomach acids, the E. coli kind of escapes the stomach acids, and then that E. coli is then able to colonize someone's intestine and potentially overtake the other commensal E. coli that is already inexistent in that person's gut. Hence those studies that looked at people going to Thailand and eating a bunch of different food that they haven't eaten before, and their gut microbiota essentially changing, and the predominant E. coli that may be colonizing their gut may then change, right? And so then you have the usual factors that come into play for someone to have a UTI, whether it's like instrumentation or sex or, whatever. And although, now there is some question as to whether or not some specific sequence types are more likely to cause a UTI, and I'm sure this is the work that Maria is working on, where there's this question of, does being a drug-resistant organism increase the likelihood of having a UTI from that gut microbiota? And so then that person ends up with that UTI, and if it doesn't get treated, it can then go up from the bladder to the ureters to the kidneys, and then can go to the bloodstream and cause sepsis in like the worst case scenario. But that's kind of, if you think of the pathway of a little organism traveling from food to causing a UTI, that would be an example.
That's great. Thank you very much for explaining that. That's really interesting. It's very cool.
Yeah, so the CDC is actually recognizing what they're calling foodies, which are foodborne UTIs. And there is actually, I don't know about right now, given COVID, but there was funding specifically for foodies in the past.
Okay. Interesting.
Yeah.
I have a question. It's nice talk, Eva. What would be though how the bacteria from the gut translocate to the bladder or to urine?
Yeah, so the way that that would happen would be, as I mentioned, the like risk factors for any UTI, maybe. So, you know, if there's, especially for female anatomy, our rectum is much closer to our urethra than it is for men. So it's, and please, if there's a urologist who wants to chime in here and has you know, other knowledge that I may not be privy to, please share. But the idea is that because of anatomy and because of, so just mechanical motion. So during sex, there may be fluids that go from the rectum that, you know, will contain E. coli that will go to the urethra, that will, you know, come into contact with the urethra. And the E. coli, being very happy to find some other place to go, will then grow and go up and divide and go up the urinary tract. Same thing with instrumentation. I mean, whenever someone is going to have a catheter or some sort of urinary tract operation or procedure, of course, everything is kept sterile as much as possible and the area is cleaned. But, you know, if a catheter stays in place for a long time, there is more chance of, again, that same kind of pathway from the rectum to the catheter and potentially contaminating the outside of the catheter going up the urinary tract. But yeah, if there's a urologist in the group who has a better explanation, please chime in.
Hi, Eva. I'm a urologist. You did a great job. Did a fantastic job explaining that. But if you think about it, really, your microbiome is everywhere, whether it's in your gut, your skin, your genitals. So whatever you're carrying around is what you're going to get when you get a UTI. And the factors that predispose to UTI are well understood: female, male, you know, various factors like having a stone, having instrumentation, having a catheter placed, but they happen spontaneously. The question is, what species do they happen with? So do they happen with what you happen to have on your body, or what a doctor introduces into your body inadvertently with some kind of procedure? So colonizing your gut with an abnormal or more pathogenic bacteria is the first step to getting a drug-resistant UTI.
Thank you. Yes, and there's more work that's being done looking at urine and realizing that it's not, I mean, just like they're doing with amniotic fluid, but there's a realization that, you know, these fluids that we think are sterile are actually not sterile. So who knows about that too.
There is
Yeah.
another comment from Maria about chicken farms, because handlers are in close contact with chickens, and chickens carry avian pathogenic E. coli, which is the same type of E. coli that causes UTI in humans. So this is just another way that people get exposed to these dangerous organisms.
And another thing I'd like to add, which we find fascinating on the research side, is the fact that with regards to transmission from the gut to the urethra, it's something that we're very interested in. And a mechanism that is been understudied is called chemotaxis. So essentially the bacteria don't need a fluid to swim through. They can actually inch onto the epithelial surface. So that's an area that's like super interesting for us in terms of like, how long does it take them to do that? And we know they can stay viable for long periods of time. So they don't necessarily need to swim through a liquid like, or the urine. They can actually inch their way by crawling across the epithelial surface.
I mean, Maria, maybe you can tell us more about this. I think there's also been question. I mean, and maybe chemotaxis is the way, but kind of translocation from the gut. I mean, people talk about leaky gut syndrome. I mean, I don't know if perhaps E. coli can react in the same way, especially if someone is having, you know, beyond the direct contact that one may have with fluids. Yeah, I'm curious, maybe this is not a correctly worded question.
I mean, so far we know that if you have inflammation in the gut and there's a burst of oxygen that allows Enterobacteriaceae to bloom there, but there hasn't been so far a connection between that and, let's say, a surge of UTI. or at
Okay.
least people haven't seen that. We do know that bacteria do bloom under aerobic conditions, at least both Salmonella and E. coli, but that's something that definitely is warranting more investigation.
Yeah, and I think your point also, I think that with the pandemic, I think that we're realizing more and more about occupational exposures. So during my MPH, I did environmental health science and did industrial hygiene also partially. And, we talk about chemical exposures and mechanical dangers of working in different fields. But I think that an understudied area in the occupational kind of medical field or clinical medical field is exposure to organisms, beyond working in a lab. And there's so much data out there regarding both MRSA and pig farms, but yeah, chicken farms and cattle farms. There's a lot of cattle farms in California, less so. It used to be a big chicken producing state, I think in the 60s and 70s, and now kind of cattle ranches have taken over. And one thing that, we wonder is are people who work directly with the cattle and in the kind of production line of beef meat, if they are, perhaps more likely to be exposed to these drug-resistant organisms and then developing infections subsequently, beyond just a skin or soft tissue infection like one would with MRSA. I think that there's been some studies that have looked at, I want to say that I feel like I've seen gut microbiota work, but yeah, I think it's a very interesting field.
All right, do we have any more questions from the group? Okay, looks like perhaps not. All right, so thank you again, Eva, so much for talking to us today. Really, some really great discussion and new information. I think we all learned something today, a little bit. So thanks everybody for joining us. Please remember to fill out the post-meeting survey if you haven't already. And a quick plug for next month. On September 9th, we will be featuring University of Michigan's newest case scholar, Dr. Julia Lane, and she'll be discussing patient decision-making in urology. So we hope that you'll all join us next month as well. Back to our usual time at 4 p.m. Central. Please enjoy the rest of your day. And yeah, bye everybody.